Hello everyone, today we're going to discuss the water seal management of a chest tube. The water seal is a 3-bottle system, and that means that it started out as a 1-bottle system. How that worked is air escaped from the pleural cavity, bubbled through the water seal, and then went out into the atmosphere. It has to go through the water so it doesn't go back into the pleural cavity. This worked great. However, as blood or effusion in that pleural space accumulates, it makes it more difficult for air to go through that water seal. Think about it like this. If you blow bubbles into a cup that's a little full versus very full, it takes much more force. So they had a second bottle. That second bottle would accumulate fluids like blood and effusions. This then made it appropriate for the air to escape from that, go through the water seal chamber, bubble through, and go out into the environment. The last bottle they added was suction, in order to get the remainder air out of the pleural space. If you think about it like a 3-bottle system, you can see how each of these bottles are incorporated into the water seal chamber. Each of the bottles, 1, 2, and 3, are found in the chest tube water seal that you use, and this makes it easier to understand the functions of each. Let's talk about bubbling in the water seal chamber. Bubbling, we were always taught, is not good. Now, when you first put in the chest tube, you're going to have a high degree of bubbling because you're escaping that air into that system. That is normal. Other physiologic things that can cause bubbling are any forceful expulsion of air. If the patient has a deep breath or takes a really large cough or anything like that. If the patient moves and escapes some air while they're trying to get out of bed, you might see that. It's the intermittent bubbling that is not such a factor. The continuous bubbling, though, usually indicates a leak. How we discover the leak is we always start with the patient. Look at your dressing and make sure there's no sub-Q air and the patient is still doing okay. From there, we can assume that it's not within the patient. We then clamp the chest tube closest to the patient for a short amount of time and continue to look at our bubbling. As we go down the chest tube, we wait until that bubbling stops. When that does, we found the area of the chest tube that has the leak. If you go all the way down and you get to the actual water seal chamber itself, then you know it's within that actual chamber and your equipment has a crack in it. The biggest take from this is that always make sure the leak is not within the patient themselves. Start with the patient. The equipment is easy to change out. The patient is a different story. Next, we're going to discuss titling. Titling is an essential function to ensure that the chest water seal chamber is working. When a patient is non-intubated and they breathe in, that negative force pressure causes the little ball to increase or go up. When they exhale, that positive pressure will push the ball down. It is the opposite when a patient is intubated or on positive pressure ventilation. Some reasons you can have decreased or no titling are going to be, first, physiologic. Some physiologic causes would be the patient not taking really deep breaths. If they have a low tidal volume or they're having small breaths, you might not see a high degree of titling. Remember, the titling is caused by the air that goes into that system. If there's not a lot of air going into that system, you're going to have minimal titling. Other reasons for minimal titling may be because the patient's lung is fully expanded. Again, if there's not a lot of air in that pleural space, then you're going to have minimal titling because now we're not escaping a lot of air. Now, those are the good physiologic things. Pathologically, one can be a large leak. If you have bubbling like the last video showed and no titling, you probably have a large leak. That air is not going through the actual chest water seal chamber, it is escaping somewhere else. And or the actual tube is kinked. In essence, I don't want you to remember positive or not positive pressure ventilation as far as titling goes. Just remember that titling is an essential function, but there might be other reasons you're having minimal titling occurring. Next, we're going to discuss suction. Usually when a chest tube is freshly placed, we're going to put these patients on suction. The question is, do we put them on suction or no when we're transporting to, say, the CT scanner or in transport with the patient? The biggest thing is with suction, if you decide to take the patient off suction, you need to be aware of your patient. Such as if the patient starts to have increased shortness of breath or difficulty breathing, they might need to go back on suction because that air is now accumulating again in that pleural space. On the contrary, if your patient's on a ventilator, when we use the DOPE mnemonic, P for pneumothorax is one of the causes of increased pressure. If the RT or you notice that your pressures are increasing and you're having a difficult time ventilating this patient, as per example of decreased VTEs or low tidal volumes, then we need to put that patient back on suction. So again, I'm not giving any medical advice not to go on suction, but if you choose not to, you need to be aware in looking at your patient and be ready to put them back on suction. The last caveat to suction is the doctor or the provider will usually order a suction number. Usually -20 is a good starting point. Remember that wall suction is not very essential. We just need enough wall suction to have that orange bevel come out. If you look in the window or the suction window and the orange bevel is not out, you are not on suction or something is occluding the actual suction tubing. Again, wall suction is still needed, but you don't need to crank it as high as it can go. Just enough wall suction to ensure the orange bevel is out. Now let's talk about if the chest tube becomes disconnected, and by that I mean the chest tube falls out of the chest. Now that can happen if it wasn't sutured correctly or was not secured. The biggest thing is to assess your patient. Sometimes, as with pneumothorax, a chest tube does not need to be replaced. If the air was escaped by putting in the chest tube, the patient might be able to self-heal and not have reaccumulation of air. However, with a hemothorax or a pleural effusion, if the cause is still occurring, that blood might be sitting behind the lungs and a chest tube may need to be placed in order to drain off the remainder of blood. Some things a provider might do if the patient looks like they're retensioning is use a finger thoracostomy like technique where they'll put their finger back into the hole and assure the air is escaped. Again, you created a window into the thoracic cavity. Therefore, just simply putting your finger in there might be enough to actually escape that air. The other thing we're also taught is to put a three-sided occlusive addressing. And when that ensures when the patient breathes in, the air is not going through the hole, it's going through the mouth and then out that hole. That's why it's only three-sided. Air through the mouth, out the hole. If it's not tightly secured, air is going to escape into that hole while also going through the mouth, and that patient may retension. Thanks for listening to this video. If you enjoy it, go ahead and give me a like, and we'll see you soon.